Hello, everyone. Oh, it's great to see some familiar names and faces. And I even see Ariel in the audience. Great to see you. Yes, I see. Yep, I see Frank is here. Frank, good, always good to have you on. And Kevin, of course. Kevin, you're like a bad penny. You just keep turning up. I don't know. Oh, I'm teasing you, man. It's always good to see you. I appreciate you being part of this dialogue. Always value your feedback and presence. So great to see everybody. Looks like a couple folks are still getting settled in virtually, so let's give them a chance to get their audio going. Um, Ayana, it's good to see you on. And Deborah, of course, you are a strong supporter. Always love to see you on these events. Oh, it's good to see everybody. Well, we've got some material to cover today, and I think most of you know my name is Steve Steiny. I'm one of the managers here at the National American Indian Alaska Native Addiction Technology Transfer Center. As some of you know, this essential substance abuse skills training, these modules are designed really to perhaps help those just getting into the field sort of build a knowledge base or add to maybe some things they have. But it can also be a great refresher for those of you that have been practicing and consider yourselves experienced or a veteran in the behavioral health field. And this series really focuses on SUDs and related things related to that. Today, we are going to cover some basic counseling skills. This is module 4 in this series of 12. And I have with us Dr. Avis Garcia. I'll introduce her formally here in a moment, but Avis is here with us. She is currently in Montana, but I know she'll be moving back to Wyoming soon. So really glad to have her here. Always a pleasure, Avis, to see you and to work with you in this capacity. So welcome, everyone. This is the Esas Basics Counseling Skills Module 4. And I'm going to go through just a few introductory slides, and then I'm going to turn things over to Avis to lead us through the lecture today. We're hoping to have a chance to stop and maybe take some questions, but I want you guys to use the hand raise feature or the chat box. I'm going to try and watch that, keep an eye on that. But we're hoping to have a dialogue too, and maybe hear from some of you. I've got to let folks in here that are in the. I'm going to disable that wait room, so let's get everybody in here. I knew there was something I forgot, Avis, and we had folks trapped in the wait room. I'm so sorry about that. Those of you that got stuck in the waiting room, welcome you all. Now we've got a group, Avis. Now everyone is here. So sorry about that. Those of you that are just jumping in, I saw that the wait room was still enabled, and there were several of you that were trapped there in the wait room. So one of those Zoom dynamics that we just are still trying to learn about. But great to see more names and familiar faces joining us here this morning or this afternoon, depending on where this broadcast finds you. Let me go through these slides, and then I'm going to change slide decks and while Avis introduces herself, and we'll go. So great to see everybody. Let's get started. As most of you know, This event is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. We are located at the University of Iowa, and we are part of a larger national network made up of 10 regional centers, a national Hispanic and Latino HTC, as well as a network coordinating office located at the University of Missouri. And again, as most of you know, we are funded and supported by SAMHSA. The content of today's broadcast is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA HHS or the National American Indian Alaska Native HTC. Again, we will follow up with all of you post-event and reach out to you via email. We will make these slides available in PDF form. So if you would like to use those for your benefit, please use them responsibly and be sure to give credit where it's due. We're also recording this event, so we'll be able to offer you a link to our archive of recorded events, and you could share that link with a colleague or a friend that wasn't able to join us today. We are going to offer 1.5 CEUs that are NADAC approved. You can request those at the time that you receive the follow-up email. And lastly, we will also ask that you consider completing a short survey. This helps us know how these kind of events impact you and the work that you do. We really value your feedback. You don't have to complete the survey, but we would really appreciate it if you did. It lets our funders know what kind of work we're doing, and we get some good feedback from all of you, and it helps us continue the work here at the center. None of that information can be linked to you personally in any way. It's completely confidential, and you can skip any questions that you don't want to answer. So if you have any questions about that survey, please feel free to reach out to me here at the HTC Center, and I'd be happy to talk with you about that. I know we're gathered here virtually. Before we begin, we would like to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement that was created by 3 former members of our team, Ella and Keely Driscoll and Mr. Sean Bear. Thank you. Well, without further delay, I want to introduce our speaker today. She is a colleague, and I also consider her a friend. Dr. Esas Garcia is here. She is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. She has many years of experience. That's just what I'll say, Avis. I'll just leave it at many years, and I'll let you talk more about that. She's done a lot of work in the SUD field and really specializes in SUD treatment approaches in working with Native American populations. She's got a lot of experience. I've always enjoyed talking shop with Avis. We both come from a clinical background, and I've really enjoyed getting to know her over the years. So Avis, welcome. And I'm going to mute myself at last. Yes, it's happened. I'm muting myself now. So Avis, you have the floor. While Avis is introducing herself, I'm going to switch the slide deck. So thank you.
Good morning, everyone. Thank you for taking time out of your busy schedules to attend the webinar that we're presenting today. He did a pretty good job of introducing me. I am from the Wind River Reservation in Wyoming and am a member of the Northern Arapaho tribe. And I'm also Eastern Shoshone. My father was Shoshone. And I'm currently working on the Crow Reservation, working for Absolagay Healing as the clinical supervisor and director of a grant for the tribe. I am transitioning to return to my homelands in Wyoming in a couple of months, close to that anyway. But as Steve mentioned, I have been in the field for 21 years, going on 22 years now. Man, time's flying. I never thought I would be saying that, but
It sounds better when you say it that way than me saying it. So
yeah, that just gives you an idea how old I am. I am dually licensed in Wyoming and Montana as an addictions therapist and a mental health clinician as well. So I have all the years of experience. So as I do my presentations, I'm usually telling stories as I do it because that's just how I teach. Today we will be um, going over the basic counseling skills, and keep in mind that this is to prepare you, or those of you that are planning to sit for the licensing or certification exam. I know different states have different criteria to become certified or licensed, and it's really different in Montana than it is in Wyoming. And for me, it was licensure. So the exam can, just the word exam can probably give some people a little bit of anxiety. But I assure you, if you're already working in the field, there's a lot on the exam that will come from your actual work practice. So today, in addition to the basic counseling skills, we'll go on ahead and get started. I have several slides, and I'll try to get through these as best I can. The objectives of today's presentation is counselor development, micro counseling skills, counseling theory, some self-disclosure and keeping clear boundaries, and finally, the cultural and ethnic issues. A person's substance use is not the problem, but rather a symptom of an underlying issue or issues for which they have yet to find a meaningful solution. And being in the field as long as I have, every person has a story that they bring that brings them into counseling. Can go to the next slide. Counselor development is where we're going to start. So to begin with, this just points out that there's some different thinking. We have global thinking, so that's just the big picture. Some people tend to think, when they're asked to think of something, they'll think of the whole thing, the big picture, versus linear thinking. A linear person will tend to think in a straight line, or like in a hierarchy, that everything seems to follow a perfect order. So those are the two different types of thinking that is being presented here today. I don't know, I'm more of a linear thinker than I am a global thinker, but this is just to point out that there's differences. Can go to the next slide. This is more on the linear thinking process. Again, linear, step by step. Just as we go in order, we follow things in order. Again, the difference between the circular and the linear. Again, global is just a big picture. Some people just tend to think like that. So that's just the differences in the thinking process. And we'll move on to the learning process next. Okay. The learning process is the different styles of learning. So some people are visual learners. They need to see examples. Auditory are the people that have to listen. And then the kinesthetic can be the hands-on kind of people. They like to get their hands in it or be more involved with it. So as you can see, the visual, like guided imagery, copies notes, uses flashcards, color coding, diagrams. The auditory is more listening, aloud, oral instructions, lectures like today, word associations, group discussions, music, lyrics, and TV. And kinesthetic is games, problem solving, writing notes. So those are the different types of learning. And how do you learn and process information? Are you a global thinker or a linear thinker? How do you process information when it is presented to you? Have you ever given that any thought? Who in your life do you believe processes information on the other end of the scale from you? So sometimes you might meet someone who has a whole different way of solving problems. How do you adjust your communication when speaking with a person who processes differently than you? And then the visual, auditory, or kinesthetic. I like to think of myself as a kinesthetic learner, meaning we do all the different types of learning and not just one. Can go to the next slide. We have some questions here. A poll question number 1. What type of learning process do you most identify with? And this is for
We're not going to do an official poll, but this is just more for thought.
This is to be mindful for us that are working, and when we're working with people, to keep in mind that some people really like to get the worksheet so they can put their hands on it, or have some activities that you can provide for them to, uh, again, put their hands on things and be involved in the learning process.
And we're getting a few responses. If you want to post
Okay.
in the chat
Okay.
what kind of learner you are, this will give
Okay,
us kind
cool.
of an idea.
Thank you, guys.
Yeah, that's true. One, it does depend on maybe who you're working with, but the question really is asking how do you best learn? What's your best way that you learn? Maybe a new skill or uh, something new that you're incorporating into your work or even into your personal life.
Okay, we can go on to the next slide. Thank you, guys. We will talk about the integrated developmental model. This is the integrated developmental model by Stoltenberg, McNeil, and Delworth in '88. This is the process of where clinicians develop in a step-by-step process. Clinicians are seen to move through 3 levels of development in a relatively orderly fashion relevant to professional activities. This model allows for brief regressions when clinicians are faced with new or ambiguous tasks. For many people, I have to, in a way, in my job as a clinical supervisor, I am supervising, but I'm also teaching people. So a lot of times I appreciate it when my staff ask me, am I doing this right? Can you give me an example? So I have to remember that it took me 21 years to get where I'm at. So these people need time to develop the skills that are going to take time to learn as they build their own foundation and find their own way of working with people. So I tell people, don't follow what I say and don't go by the book. I've met some people fresh out of college that are strictly from the book. So it's finding your way that you feel most comfortable in working with people. It's kind of like building your house. You build your foundation. We can go to the next slide. The integrated developmental model shows that people are continuously growing, and growth is not linear, but sporadic. So we tend to move in spurts with that. Your growth can be affected by changes such as caseload, your treatment setting, your relationship with your supervisor, and the population served. So that is really true depending on the different people that you're working with. So they always present new challenges that we have to get some training or teach ourselves through getting some books on whatever topic that we need to get more knowledge in. Levels of counselor development. There's the beginning, the intermediate, and the advanced. So the beginning for me is someone fresh out of college. The intermediate could be somebody who's been there for a few years, maybe 5, 6 years, and the more advanced is going to be beyond that. So as you gain more experience and you're more comfortable, you learn a lot more about different interventions and different types of theories that could be used. You start to become more advanced. I know in Wyoming, they don't allow you to practice independently until you've been supervised for, I think, a couple of years. And the integrated model has 8 growth areas. That is intervention skills competence, assessment techniques, interpersonal assessment, patient conceptualization, your individual differences, your theoretical orientation, treatment plans and goals, and professional ethics. So the level of counselor development, the beginning level 1, intermediate level 2, and advanced level 3. So level 1 clinicians are full of trust and hope. Level 2, there may be some confusion, striving for independence. They don't want to copy other people by imitating someone. They may have rigid attitudes and belief systems with a little bit of ambivalence and instability, and that's perfectly normal. That is perfectly normal. So um, it takes continual practice and work in the field to feel more competent. And level 3 is the calm after the storm, being able to concentrate demonstrates development. Learning is a lifelong process. And those of you who've been licensed or certified know that we're all required to get continuing education, which is to continually educate ourselves and learn. We can go to the next slide. Now we are going to get into the micro counseling skills. These skills can be learned, but I would say that those of you that are listening today um, have many of these skills already, or you wouldn't be in this field doing this work. Okay, to start off with, micro counseling skills is something that was termed by Alan Ivy, a professor from Massachusetts. He is an author of and co-author of more than 40 books and 200 articles translated into 18 languages. He is the originator of the micro skills approach. So that is Alan Ivy. Go to the next slide. Micro counseling skills. Here's a couple of books that, if you don't have them, might be very valuable resources for your professional library. If not personally, I would recommend them for your program. This is Intentional Interviewing and Counseling, Facilitating Patient Development in a Multicultural Society, Essentials of Intentional Interviewing, Counseling in a Multicultural World. Both by Alan Ivy. See his name there? Okay, micro counseling is an analysis of counseling skills that looks carefully and in great detail at the elements of the counseling relationship. Regardless of the aims and methods of the counseling relationship, understanding the micro elements helps the clinicians to improve their counseling effectiveness. So when they talk about doing micro counseling, when you're working with people, it is the little things that you'll see in the next slide that we break this down. The first would be your attending and attending behavior. So the counselor's interest in the patient demonstrated by your eye contact, your body posture, and your accurate verbal following. And your attending behavior encourages the patients to talk and active listening. So we really need to be listening to what the clients are saying so that we're able to reflect that back to them. They need to feel heard, they need to feel understood. Um, so this is a skill that you build, and sometimes you need a little time to prepare yourself. When I see clients, I like to know that I have time scheduled before that session so I can mentally prepare myself, even before a group. We can go to the next slide. And here's the open and closed questions. Open questions, you can't answer those in a few words. Offer encouragement and the patient will speak more freely. So maybe you could, tell me more about that, or, you said this, but help me understand it more. Can you give me an example of, when this has happened? Closed questions are basically your yes or no. You don't want to get caught into the question and answer trap. Oftentimes when you're doing assessments, you are just focused on yes, no answers. But when you're actually working in group or working in individual counseling, you need to be practicing use of open questions. And go on to the next slide. Patient observation skills. This is your reflective listening. So our nonverbal behavior is 85% of our communication. We need to pay attention to our verbal behavior, the key words that you're using, and look for discrepancies in patients' communication. So there may be mixed messages, there may be contradictions, there may be some conflicts and some incongruities. And oftentimes, I think I pick up on this more in the assessment process of they may say one thing in one situation, but say something different, but being able to point out, well, wait a minute, you said this, but now you're saying that. So which is it? The task is not to problem solve, but to understand where the patient is coming from. And that's exactly what you would want to say to them is, I'm trying to understand where you're coming from to get your point. Again, this is from the Alan Ivy book. Go to the next slide. Encouraging, paraphrasing, and summarizing. This is your reflective listening. This is where you're using your listening skills the very most. So you want to be encouraging to the clients, paraphrasing a lot of the words of what they said to you. This is what I hear you saying. Am I right? And then summarizing. So summing everything up at the end and giving it back to them, but also encouraging. Being very encouraging is real important in substance abuse work. Always being encouraging to your clients on a daily basis. You can go to the next slide. Reflecting feelings, the patient's feelings, either stated or implied, as expressed by the counselor. I'm getting a sense that you're unsure of yourself, or you might have some anxiety, or you might not be, are you feeling you have something going on that you need to share? And again, the feelings of the patient can be nonverbal and verbal. I think a lot of what I see a lot is people with that wear hoodies. And so for me, it makes it hard. And so I have to ask, can you take your hoodie off so we can see you better? The reflecting meaning is the next slide. Finding the deeply held thoughts and feelings underlying their life experience. Paraphrase is to thoughts as reflection is to feelings. and breaking down the complex behaviors into parts. This allows you to confirm and affirm where the patient is in their recovery process. And the next one is empathy, understanding what the patient is experiencing and putting oneself in the patient's place. Functions of empathy builds a firmer relationship with the client, enables the counselor to better understand the patient's behavior and common problems with conveying empathy. Language and cultural differences between patient and the counselor. And to give an example of empathy, I know many people that are struggling with drug and alcohol issues. Just getting to the appointment is like huge. Like they're probably really scared and really nervous. And so being able to empathize with them that, you know what, how you're feeling is perfectly normal given the circumstances. You're probably, you know, feeling bad or having a lot of anxiety because, you know, the unanswered, a lot of my people are court ordered, our social services sends them. So just letting them know, hey, you're doing the right thing by being here today, and that it's going to be everything you're feeling is perfectly normal given the circumstances. So I try to convey that to my patients that I work with.
Does anybody have any thoughts about the use of empathy or any experiences with that anybody would want to share in their work with their relatives or patients or clients? It's a powerful tool, but it can also be something that can interfere with your work. Anybody relate to that or have any
I'll throw a
thoughts?
question out there. I
Yes.
would say in having to utilize empathy so much, maybe you could share some tips from keeping it from turning into a situation of transference or countertransference.
Hmm. It would depend on the circumstances that the individual is bringing. Um, One specific example that I was kind of thinking of that I just had just yesterday, you know, was sometimes I can tell a lot just by their behavior. I can tell some people are anxious or nervous, and just being reassuring. And I wouldn't, it again, it depends if you're, I'm the person that I'm thinking of in my mind as an example is assessment that I was doing versus if I were doing therapy. And when you have those kinds of issues, those are where you need to make note of them and take those to your supervisor to process them. So that's when you need to be mindful of that yourself. So I supervise some staff, and they come to me and tell me when they're feeling like they're having some transference or some counter transference, and really needing to step away and reflect on that. So it is, Steve quoted on here that it's not sympathy, but it's being able to understand what the patient is feeling. And so that's what they mean, putting yourself in that patient's place. And so I know from personal experience, a lot of people that come to substance abuse treatment are struggling with a lot of trauma and a lot of unknowns that we don't know. So just being there as a caring person is what I get from having empathy for the patient. Like it 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 depends if you're doing therapy with that person, where you're going to go with that. But we're just focusing on the micro counseling skills. So empathy is one of them. We can go to the next slide.
There's some really good comments coming into the chat as well. I don't know if Catherine or Frank wanted to
I'm not,
jump
yeah.
jump in and comment on this. It's great. I agree with both of you, and that's a great suggestion. You guys want to unmute and share a little bit, if you can?
I have found, I've been at this 48 years. And I've found that if I arrange myself to mirror the client's physical position and pay attention to my own body, I get a pretty clear idea of what the patient is feeling. And then that makes for a better connection.
That's a really good point, Catherine. I myself have caught myself having to be like, oh my gosh, the way I'm sitting, I'm
Mhm.
closing myself off. So I, have to be mindful of my own behavior. So that's a really good point that you make. Perfect example.
Thank you.
Frank, did you want to say something too? Your comment was also noted in the chat. I really appreciate that.
Just put me on the spot.
I know. You see, we're trying to get you guys involved. Here, you thought you were just going to be talked to for a little 30 minutes. Now, I always appreciate you, Frank, and you got some great insights. So
Okay,
it's incredibly difficult. The more we learn about this, and the more to help people. It's a lot easier said than done.
Yeah.
Mhm.
But
Thank you.
empathy is such a well, not only empathy, but so well, I'll just reiterate what I typed in the chat.
Yeah.
So, as far as the spirit of motivational interviewing, we have to have empathy for the individual, and but the relationship is really key to build a relationship with them, and I've been on both ends of that relationship, and I've never viewed it as a relationship until about a year ago.
Yeah.
It drastically shifted my perception on it, because it's really important to have that and view it as such, because then you won't open up. And of course, you talked about trying not to self-disclose. And I don't know what I'm trying to say here, but I pretty much said it here, because it's tricky not to get transference or counter-transference. Trying to.
It sure is. And Frank, I think to build on what you're saying, if we think back to those levels of counseling, the beginner, intermediate, and advanced, early on as a clinician, that empathy may be difficult to bridle and to identify. And that's why you want to have colleagues and supervisors to connect with and process. Transference can really be overwhelming. And I remember having transference with a patient, and it was so strong that I really felt like I was forfeiting my objectivity and my ability to really treat this person and connect with them in a way that I was going to do that justice. So I really had to reconsider, and we ended up reassigning her to another counselor, and that those are the kind of things that I think early on it's hard to identify, but being with that patient in the moment is an extremely powerful dynamic in that relationship that Frank was referencing. And my job as a clinician is to keep some of my objectivity. And otherwise, if I'm all in and I lose my objectivity, then I really forfeit, my role oftentimes as that provider. But it's a balancing act, and I really appreciate you sharing that, Frank. Thank you.
Yes, thank you. Okay, we can move to the next slide.
Susan was asking about patient versus client, and they're synonymous. It really, in the last, I'd say, Avis, I don't know if your experience has been this, really the last 5 or 6 years, it's really moved and followed the medical model. So using patient or client, or as some of my American Indian Alaska Native clinicians, they use the term relative.
Mhm.
And I was a little bit, I kind of bristled at first with this, but I've really embraced it. And I really think it has some additional, uh, uh, power to have that relationship with working with your relative. So they're
Mhm.
interchangeable, Susan.
Mhm.
That's the short answer. It's your preference, but it's really following that medical model as the field evolves. It can be a little clinical for some. So that's a good question.
Mhm. We can go to the next slide. This is just what micro counseling skills is the most challenging for you? Is it your attending behavior, your open versus closed questions, reflective listening, or empathy?
We're seeing some answers come in. Reflective listening can be a challenge. You really have to
Mhm.
operate almost on kind of two levels
Mhm.
in that session to be able to accurately reflect
Mhm.
what you're hearing. And if the patient says no, that really isn't, you've missed the mark. That's a great way to sort of check where you're at and what you're hearing versus what the patient's trying to convey. Yeah, and open
Mhm.
and closed are always a challenge. I think,
Mhm.
uh, I was always uh, guilty of asking two questions at once. before before that relative could respond, I was asking another question. So
Mhm.
um, yeah, that's good. Thanks for and Catherine says when she started in this field, she had to write a letter to the court about a male patient. I had a coworker read it, and her comment was, "Gee, you're really angry." Oh, that's interesting. Thanks for sharing that. Yeah, there's some transference going on right there. That's wow. That's a great example, Catherine.
Mhm.
Is yeah, and Ayana's saying empathy, and I agree too with that. I've been kind of pulled in, and it really is a different kind of energy to over empathize or uh,
Mhm.
really feel like I have to solve this or feel real overly obligated.
Mhm.
We'll talk about self-disclosure too. Avis will talk about that in a little bit, and it's
We're
tied to
getting there.
that. It's really tied to that. So,
It is.
okay.
Okay, we're going to get into counseling perspective theories. The first one is the psychoanalytic perspective, consisting largely of using methods to bring out the unconscious, working through past transference relationships, focusing on childhood experiences. This perspective is the training is beyond the scope of most clinicians. An advanced degree in psychology or psychiatry is necessary. So this is because it comes from Freud. Those of you who've had counseling 101, I think it's 1000 now, well, our psychology. The psychoanalytic perspective comes from Sigmund Freud. And this is the struggle between the life and death of instincts at the heart of human nature, dynamics of the unconscious and its influence on behavior, role of anxiety motivates us to do something. Personality structure is divided into components of the id, the ego, and the superego. And development of personality at various life periods. Erik Erikson broadened the developmental perspective beyond early childhood, established a balance between ourselves and our social world, biosocial approach. Crisis is equivalent to a turning point. Ego, developing strength and ways to deal with life's tasks, and personality stages. And Steve is in the chat box saying there are some questions on these in the test. So I would suggest making notes of each therapist, maybe this one slide, for example, of what their perspective is. So that's Carl Jung. He's just taken Freud's perspective a little further and focusing on the developmental aspects of life. And we can go on to the next slide. Okay. Overview of the psychoanalytic perspective, the limitations, lack of ego, strength needed for change, biological predisposition, great responsibilities placed on parenting, the mothers and fathers, and the cost is long-term therapy with difficult measurements of outcome. So this is the psychoanalytic perspective is somebody who will go to therapy for years. And again, more of the Freudian approach. And yeah, it's putting the responsibility on the parents of what your parents did to you is why you are the way you are. Contributions, it gives a conceptual framework for looking at behavior. Past experiences pertain to the current life, value and role transference, overuse of ego defenses can keep patients from functioning effectively, and role of early childhood development. So we can go on to the next slide. The Adlerian perspective is Alfred Adler. The goal is to help patients identify and change their mistaken beliefs about life and participate more fully in a social world. People need to understand and confront basic mistakes. Family is a very important factor, and cooperative therapy between the clinician and the patient. So we still have quite a few slides to go over, so I'll try to speed this up a little bit. Again, there's limitations to the Adlerian perspective, difficult to empirically validate the basic hypothesis, detailed explanation of early childhood. And for most of the substance abuse work, there's not so much focus on the early childhood, but what I focus on mostly is the here and now. You can go on ahead and move to the next slide. The existential perspective is Viktor Frankl and Rollo May. This is another philosophical approach that influences the counselor-patient therapeutic process. We are not the victim of circumstances to a large extent. We are what we choose to be. Self-awareness in therapy is key. The process of searching for the value and meaning in life looks at the individual worldview, and people are faced with anxiety of choosing to create an identity in a world that lacks meaning. And the next slide, we're going to send you these slides. So if you want to look at the limitations and the contributions, you can. I think the main component when you get to the exam is going to be the basic information that we show on the first slide. So the next slide with Carl Rogers, the person-centered perspective. You can move the slide, Steve. Person-centered perspective is really huge in substance abuse treatment. Well, it's been a while now, but we're CARF accredited, and CARF requires us to have person-centered approach with everything, like even the materials we put on the wall or hand to clients, they have to see the person-centeredness come out in those. So this is an important one to know. It's a self-directed growth potential for understanding the self. The therapist's role role is to be rather than do something, focuses on the person. And for my opinion, this person-centered perspective is giving the client the choice in their therapy. So when they do their treatment plan and what they want to cover. So I tell them, this is your plan, this is your program. When I'm opening up a session with them, this is your time. You know, what do you want to talk about? So that we're there to let them take the lead because they know themselves better than anyone. Again, there's limitations and contributions. What I like about it is it's non-directive. We're not directing anything. We're letting them take the lead. Skip on to the next slide. Motivational interviewing. This is huge. Very helpful in the substance abuse field from my perception. This is by William Miller and Stephen Rolnick. And they also have a very excellent book. This motivational interviewing can be a whole training in and of itself. Takes a lot of practice. I always tell people this is another book you want to add to your professional library to really understand it and apply it to your work. So this is helping the people to become more motivated in doing the work that it is we hope they'll do by getting into treatment, really getting them motivated and keeping them engaged. Steve is making comments in the chat box that it really does fit with Native American culture. Again, like I said, this can be a whole training in and of itself. It's a form of directive, client-centered psychotherapy where patients are encouraged to explore the discrepancies between what they hope to attain in their lives and how they currently live and behave, using specific language and techniques to empower patients toward positive lifestyle changes. I said, this is huge in substance abuse. So this is endorsed by SAMHSA as one of the most effective, extensively applied in treatment. Limitations and contributions, doesn't address urgency of change. No methodology for resistive patients. Triggers change in high-risk lifestyle behaviors, increases the willingness to get help and fight through addiction. Like I said, motivational interviewing is like a whole process in itself that I really recommend you get some training in using it. It takes a lot of practice to apply it to your work, but it will be on the test. Can go to the next slide. The Gestalt perspective by Fritz Perls is based on the premise that people must find their own way in life and accept personal responsibility if they hope to achieve maturity. The therapist is not there to change the patients, but assist them in experiencing all feelings, avoid interpretations, and focus on patient's behavior and focus on patient self-awareness. So just mostly increasing their self-awareness. Again, there are limitations to the Gestalt perspective. Not anything I've ever felt comfortable myself using, but I have met other therapists that they say they're straight Gestalt. And I don't, I'm trying to say I haven't, just because I don't use it doesn't mean other people don't use it, but it does, it's a different approach. Again, for some therapists, they find that more appealing to them and apply it. Steve's talking about the empty chair. Yeah, so as with any theory, there's the limitations and the contributions. So like I said, these slides will be available to you. William Glasser, control and reality perspective. This is one of my favorites. I really like this. William Glasser rejects the medical model, looks at patients live in an external and internal world. So we see things differently inside than we do outside, that there's these two different worlds that are parallel. The clinician's function is a teacher or a model, focus on personal responsibility and gaining control, looks at total behavior, and patients have psychological needs for belonging, power, freedom, and fun. So I believe every person is looking for a sense of belonging in the world. And this really seems to fit with my approach to working with people. Also known as choice theory. He has a couple of really good books. The control reality perspective, again, the limitations and the contributions. The limitation is the emphasis on the counseling process, doesn't take into account the unconscious. And to me, I'm more focused on the conscious. I guess that's why I find this more appealing. Short-term focus dealing with conscious behavior. So it's the contribution. It's a contract approach. Punishment and blaming is a basic reality, and psychosis can be related to unfulfilled needs. Can go to the next slide. We have the behavior perspective. This is by Arnold Lazarus. Interplay between the individual and the environment, emphasis on specific goals at the onset of therapy based on scientific method. Patients are expected to engage in specific actions to deal with problems. Therapist uses summarization, reflection, clarification, and open-ended questions. Those are all those micro-counseling skills all in one sentence right there. Therapy is a collaborative partnership. Somebody had just mentioned it earlier. That relationship is very important. And there are 3 major areas of development. So this is Arnold Lazarus. Again, there's the limitations and the contributions, changes behaviors but not feelings, ignores importance of relational factors, doesn't provide insight, treats symptoms rather than causes, and involves control and manipulation by the therapist. Contributes to cognitive factors and subjective reactions of people to the environment, systematic behavioral techniques, and ethical accountability. The cognitive behavioral perspective, this is a big one for substance abuse. Almost all treatment materials and interventions are all focused on the thinking, looking at the thinking. Albert Ellis, Aaron Beck, and Donald Meichenbaum, there is the rational emotive behavior therapy that focuses on thinking, judging, deciding, and doing. Our emotions stem from beliefs, evaluations, interpretations, and reactions. Active directed techniques challenge the belief system. So when we're talking about challenging the belief system, there's a whole list of these thinking errors. Like if some people might think in black and white or catastrophizing everything. So teaching them that there are those thinking errors that need to be looked at and changed. Some people are raised to think a certain way all their life, and that's just how it was, and not seeing there's a difference. Psychological distress is largely a function of disturbances in cognitive processes. So a lot of it is focused on your cognitive behavior, is your thinking and your behavior. And the patient needs to take an active role. Again, there's the limitations and the contributions. It doesn't encourage patients to address unfinished business. Personal warmth is not essential. Potential for transference, less concerned with unconscious. Contributions, self-responsibility and maintaining self-destructive ideas and attitudes. Emphasis on putting newly acquired insights into action. So when you're teaching them the opposite of some of the thinking that they've been using, of changing that and following up to see how things work, teaches them to carry on their therapy and comprehensive and eclectic therapeutic practice. But cognitive behavior will be on your test. I can guarantee you that. We can move to the next section. the family systems perspective, there is the Murray Bowen, Virginia Satir, Carl Whitaker, Salvador Minuchin, Jay Haley, Cloma Danes, Tom Anderson, and Michael White. So there are several. Cause of problem understood by viewing the role of the family, unresolved emotional fusion to one's family, emotionally detached therapist, teacher, model, coach, the here and now interactions between family members, and techniques can include family mapping, enactments, and reframing. And I have to be honest with you, I haven't really had the opportunity in substance abuse work to do a lot of family therapy. Usually when I've done family therapy, it's mostly been in more of a mental health capacity practice where, the family comes in as a family and they have some issues identified that they want to work on. And as far as working with natives, there are some programs that are geared for family involvement. So it is really important to look at, and um, it's the family system. I feel like when we're looking at substance abuse, for example, there's oftentimes something in the family that is triggering, or that's what they're having a lot of problem with. So it's really good to help them explore their family. And if you can have family uh, activities in your program, that's really beneficial to the family itself so that they can be involved and create that support for the individual who's in treatment. Limitations, the patient may be lost in the system and language. They may be stuck. More research is needed. Contributions, neither the individual or the family are blamed for a particular dysfunction. The family becomes empowered and understanding with the individual system. So we can go on to the next slide.
And as some of us know too, those practicing in this field, involving the family sometimes is a detriment. So, I always had to be careful about, I may have wanted the family involved, but I have to look at that full picture to see if that really is in the identified patient's best interest. Family therapy can be very challenging and involves a lot of dynamics. So I'm sure those of you that have done some family work could attest to that.
Personally speaking, with my work with Native people, I have often seen some individuals come with a family member, and it's usually that family member that's the most concerned about them and wants them to get help. So when we reach that point, if I ask that client, grandma or mom might be sitting outside and they're the ones that brought them because they're really concerned about them. So I ask them for permission. If we get the proper releases signed, can we bring them in? And I feel like that's been real effective for those who do come with a family member. Like that family that person that brought them most often wants to be involved. So that has worked well for me. Not the entire family, but usually the person that's bringing them. Okay. Integrative perspective is creating an integrative stance is truly a challenge. It does not simply mean picking bits and pieces from theories in a random and fragmented manner. It's important to ask which theories provide a basis for understanding thoughts, feelings, and behavior. Must have an accurate, in-depth knowledge of each theory. You cannot integrate what you don't know. Takes great skill and training to know when, where, and why to use a particular intervention. And it is a long-term venture. I've started out very early on with a certain approach, only to learn as time went on, when you learn about these different approaches and theories, that that makes sense to me, that works. And so you incorporate that into I call it your tools. Look at your agency's leadership, your supervisor, and colleagues for support and guidance, and the caution is to do no harm. Okay, we can go to the next slide. Poll question number 3, which series are you most drawn to?
That's quite a menu there.
It is. It is. Again, a couple of these I would say are more fit for the psychiatrist or psychologist that's looking at long-term, training versus the ones I really like are, well, person-centered. It's required by my agency. It has to be for our CARF accreditation. We have to provide that. And the person-centered can be used by anybody. I have office staff that understand what person-centered is. Motivational interviewing. I personally like choice reality, cognitive behavioral. So those two work very
Yes, and
well
we're
for
getting
me.
we're getting a nice variety here. Sunshine says MI, Noel says Gestalt and analytical. But I would love to see sit in on a session with you, Noel. If you've ever watched any of Fritz Perl's old footage of some of his work, if you can see through all the cigarette smoke, you can really watch some really interesting dynamics. He was a controversial, but some thought he was very effective. Fritz Perls.
Yeah, somebody commented on DBT. I
Yes,
like that too, and I'm surprised we didn't cover that.
we've recently added that into our
Okay.
alcohol and drug exam prep training module. So
Okay.
yeah, that's been really effective in certain populations.
Okay.
Patients with
Yeah.
personality
I
disorders, and so yeah, that's thanks for mentioning DBT. So
yeah, because the NADAC their books for preparing for the exam has DBT in it. So I was like, do we not have that in here? Something we need to add. Okay, let's go to the next slide. We got a lot of good responses. We're running short on time and I still have a little ways to go. Assessing readiness to change. In general, why do you think people change? And here we go, Prochaska and D. Clemente. The stages of change were developed by psychologists Prochaska and D. Clemente in the 80s in an effort to capture the change process in cigarette smoking treatment. It has since been used to characterize changes in other addictive disorders, including alcoholism. Could go to the next slide. Here's the stages of change in a circular pattern. Prochaska and D. Clemente's cycle of change is understanding the readiness to change. Understanding the readiness to change provides the clinician with important considerations for intervention. And when I do assessments in my office, and I require all of my counselors to tell me what stage of change this person is in. And so they have a nice little chart that they actually, have the client identify where they think they are in that cycle. On to the next slides, the self-disclosure.
we could probably have a whole workshop on why do we think people change.
This really goes along with the motivational interviewing, and yes, we could. And
Yes,
we should.
yeah. So I agree, Sonia. We'll have to maybe circle back to that and have a separate workshop or webinar on why people change, or sometimes people would say, why don't people change? That's the other way to look at it.
Because they don't want to. They like things just the way they are.
Well, and as all of you know, a person's substance use is really not the problem. It usually is causing problems, but underneath what's driving that often can be identified as those co-occurring or comorbid issues that probably pre-existed the substance use itself. So
Mhm.
that idea of why people change. If I say to Avis, you need to stop drinking right now. You're an alcoholic and you need help. That alcohol may be serving a vital purpose for Avis. I don't know for sure. I haven't explored that. So I might ask Avis, instead of pointing my finger at her and telling her that she's got a problem, I might say, Avis, tell me what you like about alcohol. Tell me what you like about it. That, when I was trained in that initially, I bristled at that because I thought, I can't ask them what they like about it because then I'm condoning their use. Well, what am I doing by asking a patient? What am I doing? If I'm asking Avis, tell me what you like about drinking, what am I doing? Am I condoning it and encouraging her? No. What am I doing, folks? Somebody unmute and tell me what I'm doing by asking her that question. Frank knows.
I would say you're forcing her to look at the problem, and which is requiring her to pick it up in the first place.
Right. I'm opening the door for us to have a dialogue about why maybe she started drinking in the first
Mhm.
place.
Mhm.
And then I can assess whether she's ready to let that go, because Avis may not have found anything as of today that is as effective. So if I'm going to ask her to let go of something that she still sees as an effective means for addressing her underlying issues, I better be prepared to explore alternatives with her to address those. Um, people want to feel better, and I don't have to be the one to make you quit. I can listen and try and understand, and then that patient will reach that point where they're ready. And I'm hopefully I'll be there. I may not be there when that happens, but I can be part of the solution. Anyway, I better be quiet, or we're never gonna even get close here. I'm so sorry, Ed. But thank you though for that comment, Sonia. That really got me thinking.
Definitely, we need to have a training on the stages of change. I'd combine it with motivational interviewing. Okay, self-disclosure and keeping clear boundaries. Self-disclosure is sharing personal, emotional, and experiential information. Self-disclosure on the part of the counselor requires careful consideration. Consider the alternatives, and patient's needs always come first. So do no harm. Um, we can go to the next slide. One of the things that I use is, how is this going to be helpful to the client? How is it going to be therapeutic to share any information about myself? And I ask that of the counselors that I work with, of what are you comfortable with your self-disclosure, and where would you use it? Why? And give me some examples of why you would use self-disclosure. And I have people that work for me that are in recovery, and so um, I actually get clients that like those counselors, because they say, oh, they get me, they understand me. And she's very open in her recovery work that she does. So self-disclosure barriers can slow down or stop the sharing process. Patient may lose confidence in the counselor. The patient may move away from self-focus. So this is something to be mindful of, is like, is it really necessary? And why would you do it? So can we go to the next slide? How often did informal discussions occur? So this is based on some research that was done um, on motivational interviewing. About 42% of all rated sessions had some informal discussion. On average, discussions occurred once or twice per session. 68% of clinicians had informal discussions. 3 or more times in at least one of their sessions, and 20% of clinicians initiated informal discussions in 75% more of their sessions. So we need to be mindful of that. And when the client brings it up, sometimes I feel like they're trying to avoid what the issue is at hand that we're working on. So sometimes you have to point that out of, we were talking about this and you quickly changed. What happened there? You know, there was a little bit of a disconnect. Self-disclosure guidelines, wait, consider first, why am I telling? You know, be brief. Research suggests that long drawn out narratives considered by patients can be unhelpful and damaging to the therapeutic relationship. So keep it brief and to the point. Use I statements, make it clear that you're giving your opinion based on your experiences only. It can be easy for patients to assume that you are referring to your clinical experience and expertise, and that can be misguiding. More, consider your patient's values. Making disclosures that you know are not aligned with your patient's values are considered to be potentially damaging. We do not enforce our values onto our patients. That's big no-no. Consider the impact. Will this disclosure cause the patient to feel burdened? For example, revealing to the patient that your father recently passed and making it, turning it all onto your own self. This therapy session is not about the therapist. It's not about the counselor. It's about the patient. So we need to keep it patient focused. Self-disclosure pros on the next slide. Builds rapport and trust, provides validation to help the patient feel normal, can reduce the power differential, helps the patient feel as though they are not alone, provides a role model for the appropriate social interaction. One tidbit that I share about myself with a lot of the clients, especially those in recovery, is a lot of them, maybe they do have goals to pursue college or get some job training or whatever. So I often disclose that, you know, I'm a high school dropout. And they're like, really? I'll be like, yes, I am. And, you know, I had to get my GED so that I can get into college. And so I feel like sometimes just that little bit about myself can be motivating to some of the clients that I work with, because they've told me that. Thank you for telling me that, you know, I'm so, that's one thing that I feel like I want people to feel like they can accomplish goals in their life. They can set goals. We can go on to the cons. Can compromise your professional relationship. Again, you're taking the focus from the client, can create role confusion. So again, the patient may feel the counselor is getting too involved and can pressure the patient into disclosing when they're not ready. So a lot of times they're struggling with issues that they're just not ready to talk about. And, you know, you just need to give them their space and respect that. They need time to feel comfortable. Next slide is a poll question. How helpful do you guys think informal conversations are in therapeutic sessions? Very helpful, moderately, or a little? I think they're very helpful. Like I said, I have counselors who have years of recovery, and I like when they share about themselves. And I think it's helpful to the people that we're serving where I work.
And informal discussions can be things just like talking about the weather or talking about sports or talking about maybe a common interest. They can be light and surfacey, but I really do. I agree with Avis. I think it's just essential to
Mhm.
that relationship. Think about relations you have with colleagues or with friends or family. Those often involve informal, conversations. before maybe you get to, why you're really there that day or what you need to address. So I think it parallels a lot of other relationships. And as Ava said, we just have to be mindful of where we go with those. And
Mhm.
self-disclosure becomes, again, let's go back to the beginning, moderate, and advanced. When I first got into the field as a person in long-term recovery, I wanted to just disclose that immediately. And what a great way to, quickly bond with a patient. And I had to really temper that and learn that that's something that, you disclose maybe at the right time, or maybe not at all, or in small increments. It was interesting too. I've shared this with Avis. The clinic that I worked at for many years had a self-disclosure policy where, as a clinician, I was not able to share my recovery status with the patients.
Mm.
And that, posed a lot of challenges for
Mhm.
myself as well as the patients, because they always want to know, have you been through something like this? And,
Mhm.
for me to come back and say, well, agency policy prohibits me from sharing that. What a dry answer,
Mhm.
So I came up with strategies and ways to work around that still honored the relationship I had with the patient. So yeah, anyway, I better stop.
Okay, we can go on to the next slide. I'm looking at the time, and so I apologize if this seems a little bit rushed. It's just trying to be mindful of the time.
We'll make these slides available. So and we are recording, so you can. I know Veronica reached out to me, and those of you that are interested, we do have a YouTube archive site with all of the recordings that we've done over the years. So it's a great resource. So happy to share that with folks if you guys are interested.
Okay, culture is a key element that enhances the opportunity for change. Culture, what is it? The next slide, everything that people have, think, and do as members of a community or society, material objects, ideas, values, attitudes.
Just lost the slides, Avis. I'm sorry. I was going to try and multitask, and that didn't work.
That's all right. A
Let me
template,
get those. I'm going to
a
get those
template,
back.
a template that shapes our behavior. It's a conscious, it is dynamic, shared and learned.
You keep going, Avis. I'm going to get those back.
Okay. Our culture is shaped by our history, our religion, our ethnicity, our race, our geography, our group membership. So there are, subcultures of people that share different interests in life. To the addressing model, what does it do? It gives us a framework to understanding the diverse cultural influences and on the patient's views and the therapist's views, helps us recognize areas where we identify with the dominant group versus various minority groups, become more aware of how identification with the dominant group can limit knowledge and experience of groups we do not identify with. Why is it important? The knowledge of patient's identity gives clues to how the patient sees the world, what they value, how they behave in certain situations, how people treat them. The more we know, the closer our hypotheses will be to the patient's realities, and the greater our credibility, efficiency, and accuracy. Go to the next slide. It's called the addressing model, which is an acronym for A is age and generational influences, D is developmental disabilities, disability acquired later in life. Maybe sometimes people struggle with hearing and vision, religion and spiritual orientation for the R, E, ethnic and racial identity. S is socioeconomic status. The other S is sexual orientation. I, indigenous heritage, and N, national origin, and G, gender. So it's an all encompassing of all the different cultural aspects that we need to have in mind when we're working with people. We all have addressing areas of privilege and oppression. We tend to be more aware of areas of oppression. Privileged areas present a greater challenge for therapists, and we need to consciously work to increase our awareness about our areas of privilege. Increasing our awareness, we investigate our own cultural heritage, pay attention to the influence of privilege on our understanding of cultural issues as we work with our patients, educate ourselves through diverse sources of information. Recently, I had all of my clients do some independent research on the LGBTQ population because they identified that as one of the areas they would like some training on. So I like to give homework and assignments to my staff so that they can educate themselves on working with different people and develop sustained diverse relationships, learn from the diverse groups, not simply learn about the diverse groups. I have a cultural counselor on board, and we recently are bringing another one in. And so it's different to have people there that are there to increase the knowledge of our patients in our work. You can go to the next slide. This is Dr. Dwayne Mackey. He has the award for excellence in Native American education, research, and human rights. He also is of Dakota and the Prairie Lands ATTC, Native American Initiative Regional Coordinator, who dedicated his work to providing education to enhance knowledge to better serve Native Americans.
We have a active lectureship award in his name that we give out each year to American Indian Alaska Native professional who has dedicated their lives to helping others. So in memory of Dr. Mackey.
Okay, we go to the next slide. Just being mindful, there are 574 federally recognized tribes and Alaskan Native groups in the United States with over 250 different languages, cultures, traditions, histories, identities. More people are identifying as a combination with another race. The estimated Indian Health Service population is 2 million. And I guess it's good to just point that out because I am a Arapaho and Shoshone, and I am in Crow country. So this 2 years that I've been here, I've learned a lot about the people that I work with. They are one of the few tribes who still have their language intact compared to my tribe. So I've learned a lot of different words here from the people and have been able to make comparisons and contrasts to my lifestyle of being raised by my grandparents who were northern Arapaho. And so I often tell them, oh, it's interesting you guys do that, we do that too, we do that thing differently. So being able to be mindful of that so that we don't disrespect anyone. And these are some slides that Steve is going into that I don't have on the different bands. But for the sake of time, we're going to go on ahead and wrap this up. I apologize. Most of you who understand our Native history know that at one time we occupied this whole continent and it was gradually taken away from us. So that's why they always do the land acknowledgement at the beginning of all of these ATTC presentations, is to acknowledge every part of this country belonged to Native people at one time. And sadly, it's been reduced to small areas. And you'll get these slides that'll talk more about Native Americans. Those are some general themes of Native culture that seem to apply to most tribes.
I know we're just past the bottom of the hour, so we will make sure that we get this slide deck to all of you. I want to just thank everyone for staying with us throughout the broadcast. And of course, I want to thank my colleague and friend, Dr. Avis Garcia. I learned something about you today, Avis. I didn't know that you didn't finish high school. Wow, that really is, wow, just blew my mind. And look at you
Wow.
now. Look at you. That's fantastic.
That's why I share that with my clients, because
Yes,
I too made some bad choices in life. I thought I was too cool for school at one time in my life.
yeah,
And
yeah. So I do want to thank everyone, and yeah, we're hoping that this kind of presentation will help those, like Catherine, who's been around the block a few times. And that's how I'm putting it, Catherine, just to be as respectful as I can. I know, but yeah, or those of you that are just entering the field. So we're really happy to have you all on. Avis, what do we have up next month? I'm looking at my, if the system goes down, I'm going to have this whiteboard that I'll
that's what I was
remember
going to ask.
everything.
That's what I was going to ask you. I think we are going to be talking about HIV
Family.
and AIDS.
Actually, May is family counseling.
Okay.
Yeah, May is family counseling, so be sure
Okay.
and join us next month, first Wednesday of the month, and we'll talk about family counseling as it relates to the treatment of STDs and co-occurring disorders. So, thank you so much, everybody. Great to see some familiar names and faces. Ariel, thanks for coming on. Great to see you. And everybody, please take care of yourselves. Until next time, stay safe. Stay healthy, and most importantly, stay connected. Take care, everybody. Appreciate you guys.